record.
So our group was assigned Down syndrome, and our age group was for a 3-year-old. So that is what our presentation is going to be on today. And we wrote a case study on Ryan. So Ryan is a 3-year-old boy living with Down syndrome. Ryan's mother and father are concerned with his ability to engage in physical activity and interact with peers in the community. Ryan is uncoordinated when walking towards his siblings and toys, often needing support from the couch and tables around him to keep from falling. He can communicate with his family successfully using facial expressions, but he struggles to communicate with peers as he has difficulty forming sentences. Ryan does not grasp his toys appropriately and often has difficulty holding his utensils to eat daily meals. During mealtime, when Ryan is able to use his utensils, he often knocks food off of his plate by accident. Ryan dislikes the feeling of certain clothing materials, walking barefoot, and food textures. He often has outbursts when in contact with new tactile stimuli. Ryan's parents expressed the need for occupational therapy intervention to learn how to best support their son in and outside of the home.
All right, for impact on occupational performance, some of the ADLs that were addressed are feeding, dressing, and functional mobility. For play, he had like difficulty participating in play and maintaining balance in play. He also had trouble with leisure participation and social participation, specifically communication with his peers.
So this is something that we have already learned about earlier this semester, but we just wanted to reiterate during this presentation. So we wanted to mention the principles of effective interventions. And these are just things that we hope to carry on through as we become occupational therapists. So to make sure that the intervention is child and family centered, it is strength-based, it is comprehensive evaluations, it is goal-oriented, it is effective interventions and outcomes, it is conductive and inclusive in natural environments. We are culturally competent and grounded in theory and evidence. Okay, and then after we listed Ryan's parents' concerns, we thought of 2 different assessments that we could possibly do. And the first one is the Peabody Developmental Motor Skills, which we all know we've done so much of that. And it is for ages birth to 6 years old. And the purpose of the Peabody is it focuses on 6 gross and fine motor subtests that measure reflexes, sustained control, locomotion, object manipulation, grasping, and visual motor integration. So we thought that this would address Ryan's parents' concerns with himself feeling unsteady while he's walking, and as well as grasping his toys and using his utensils. So the next one that we talked about was the Carolina curriculum for preschoolers with special needs. So this one is more focused to children with special needs, whereas the Peabody would compare our child Ryan to a typically developing child. And this is for age birth to 5 years old. And the purpose of this evaluation is to help evaluate the progress in 5 developmental areas and encourage children's development throughout teaching activities. And the 5 developmental areas within this assessment are cognition, communication, social adaptation, fine motor, and gross motor. So we thought this assessment could help focus on Ryan's parents' concerns with his communication skills, as well as his social participation within the community and his friends.
Okay, so now we're going to talk about an occupational therapy intervention. So first, we want to say that neurodevelopmental treatment therapy can be used for hypotonia, which is weak muscle tone. And it may focus on proper handling techniques, improving reach and grasp for functional play, weight bearing, crossing midline, and weight shifting techniques. So first thing we're going to address is the fine motor and gross motor skills. So for parent education, we're going to inform his parents on fine motor and gross motor development specific to his age group, what he should be completing at this age, what he should be able to do, how he should be able to interact. And then related to large muscle movements like his legs, his arms, postural control, and his trunk. and then massage should assist with his hypotonia. And then for the occupational therapist intervention, we're going to do some type of obstacle course to kind of facilitate basic sequence and direction, following gross motor coordination. And then for visual stimulating toys such as squinch and tongues can enhance coordination and strengthen his hand, and also address visual motor integration. For visual perceptual skills, we're also going to kind of educate his parents on what that looks like on an everyday basis, and how that can impact him, especially when going out into kindergarten, first grade, and so on. For OT intervention, we're going to do like a puzzle to kind of increase his ability to learn new skills, also facilitate visual perceptual skills, visual and orientation, and hand manipulation.
All right, so for occupational intervention, often like in children with like Down syndrome, they might have like sensory issues. So for Ryan specifically, he had like trouble like keeping his clothes on. Like he had an outburst because like he was very sensitive to like sensory input. So like occupational therapy might use like the principle of sensory integration to just help regulate arousal levels. So educating the parents on sensory integration is very important, and addressing it and recognizing the sensory integration. Some of the OT intervention that we could use in this case is develop a sensory box, and allowing like the child to like bounce on the ball or swinging on the swing, or even like spinning on the board. We can also use like activities like tactile activity, just like playing Play-Dohs. Yeah.
So the last area that we wanted to address when it came to Ryan were his self-feeding skills. From the case study, we learned that he was having difficulty keeping food on his plate and being able to hold on to a spoon. So the first thing that we want to do is educate the parents on adaptive devices and positioning that they could utilize for his difficulties. So the first thing we would look at is if he has supportive seating while he's feeding. This would help assist with postural control, which would allow him to have better control of his fine motor skills. Along with that, we looked at adaptive devices that we could use. The first one that we looked at was his utensils that he'd be using for feeding. As you can see in the image, we chose this grip that you can put on any utensil, so you can switch it out between the spoon or a fork. It has a wider handle, which will help him grasp it better, but along with that, it has a strap that'll go behind the back of his hand, and that'll hold the utensil in his grip, and it would make it a lot easier for him to keep it while he's eating. The second adaptation we looked at were using a plate guard or having a bowl like the one that you see in the image on the lower part of the screen that has a higher side to it. This will allow him to scoop food, and he can use it and press the spoon up against the side of the bowl in order to keep all of the food in the spoon. It also has a suction cup on the bottom of the bowl, which keeps it from moving around, which will be a lot easier for him while he's eating. Some interventions that we can work with him through are using Play-Doh to help increase his fine motor strength. So in the future, he will be able to hold the spoon independently. We can also use nesting bowls and use a material like rice and have him scoop the rice into the bowls to practice using a spoon. He can also lift the bowls and pour the rice into another bowl. And this will help in the future if he, is pouring his juice or something along those lines over the next few years. We also wanted to look at a way you could grade the activity. So for him, for feeding, he's having difficulty with the stuff falling out of his spoon. So to grade it and make it easier, we could start by having him practice with substances that are sticky, like yogurt or oatmeal. They'll stay on his spoon a lot easier for him to be able to bring it up to his mouth to eat. And then the last thing we wanted to utilize was reverse chaining for self-feeding. So as the occupational therapist, we would do the first however many steps, and then we'd have him do the last step of feeding. So this might be, we'd bring the sputum to his mouth, but we'd have him put it into his mouth. And then once he's able to do that step, then we'll work backwards from there. And these are our resources.